invite Dr. Nameeth to present his talk on does switching really helps in switching off the diabetic macular edema. Over to you, Nameeth.
Good morning, everybody. Thank you, Dr. Manjunath, for giving me this opportunity. So does switching really switch off DME? So as we all know, anti-VEGF are widely accepted as the gold standard treatment for center-involving macular edema, and the efficacies have been proved by multiple randomized controlled trials. But a large percentage of patients, they show very poor response to anti-VEGF in spite of being given for a long period of time. Protocol T showed us that approximately half the cases treated with bevacizumab did not respond and had persistent macular edema even at 2 years. Protocol I showed us that CFT never came below 200 microns with ranibizumab. Half of them failed to achieve more than or equal to 2-line improvement, and 40% had persistent macular edema even after 6 months. So why do anti-VEGF fail to work? So at this juncture, I would like to talk about two types of functional responders to anti-VEGF. One is the early responders, which exhibit visual gains of more than or equal to 5 letters from baseline at 3 months. Another set are late responders, which have visual gains of more than or equal to 5 letters from the baseline at 6 months only. So the late responders could be mistaken to be non-responders. If anti-VEGF are switched too early, they can be missed. So non-responders can be functional non-responders or anatomical non-responders. It is very interesting to know that 1/3 of the patients on anti-VEGF treatment are functional and anatomical non-responders. So the exact reason for non-response is not clear. However, tachyphylaxis has been thought to be responsible because of continued drug injections and repeated drug injections. Tolerance, underdosing, sometimes the patient does not come when he is advised to come for treatment. So underdosing and non-response occurs that time. So the other causes of non-response are that anti-VEGF are not effective in all patients. It does not suppress all inflammatory cytokines, chemokines, and in these patients, anti-VEGF just doesn't work, and steroids switch is definitely required. So why to switch? Why do we need to switch? Just giving continuous anti-VEGF treatment doesn't mean that the DME has to respond, which was showed by the protocol I or restore studies, which showed that repeated injection of anti-VEGF did not ensure successful outcomes. And in RISE and RIGHT trials, the patients were identified who were likely not to achieve optimal outcomes from continuation of anti-VEGF, and these patients, when they were switched to a different class of drugs, they fared better. So when do we switch? There is no uniform criteria to switch. However, two things to be seen is that of the central macular thickness and visual acuity. So 3 different studies have gone through, and 3 different studies have 3 different criteria. So one criteria which was looked at was less than 20% CMT reduction post 3 monthly injections. That was the time to switch. Central macular thickness of more than or equal to 10%, it was time to switch. Or less than 50%, half of the reduction in excess of macular thickness, 3 to 4 months even after 3 to 4 monthly injection, it was time to switch. Coming to the visual criteria, some studies said that visual gain of less than or equal to 5 letters, it was time to switch. Visual loss of more than or equal to 5 letters, and BCVA not improving to more than or 20 or equal to 20/40, even in spite of 3 to 6 monthly injections, then it was time for a switch. So when do we switch? Protocol I showed us that the 3-month interval as a potential time for switching. Early switching is recommended before permanent structural damage has happened. So switch to what is the ultimate question? Multiple studies were done showing the efficacies of various anti-VEGF agents. RISE, RIDE, VIVID, VISTA studies, SOUZA et al., Lim et al. Multiple studies were done, and many of them two of them from that showed us that ranibizumab fared better than bevacizumab. Two of the other studies showed that aflibercept was fared better than ranibizumab. However, at the end result, although the edema came down, there was no visual improvement that was seen. That means that by the time the chronic diabetic edema was diagnosed and the treatment was continued and anti-VEGF was switched, the visual potential had been limited to some degree. So that's why an early swift action is what we should aim for. So what was the ultimate switch? In between the bevacizumab, ranibizumab, and aflibercept, aflibercept definitely had a higher visual gain, especially in the eyes with worse visual acuity at the time of presentation. Now coming to the new kid on the block, that is the brolizumab, which was the study was done, which was called the Brader study. That was an Indian study which compared brolizumab with aflibercept for recalcitrant diabetic macular edema. It showed that at the end of 2 weeks, there was no visual improvement. And in eyes either treated with brolizumab or aflibercept. However, 3/4 of the eyes treated with brolizumab, they attained full macular dryness compared to half of the eyes treated with aflibercept, showing that brolizumab switch has an edge over the aflibercept in recalcitrant edema. So the search for the ultimate switch, there has been a shift currently in the classification from non-chronic diabetic macular edema, which is VEGF driven, to a chronic diabetic macular edema, which is not VEGF driven. The current recommendation is that switching to steroids at the right time rather than switching anti-VEGF has shown better results by multiple studies. Bush et al. Showed us that early and late eye switch to dexamethasone implant demonstrated improvements in visual acuity and macular thickness greater than those seen in anti-VEGF monotherapy group. This is a chart showing a meta-analysis of a huge study comparing two huge groups of anti-VEGF group and a dexamethasone group. You can see here that there are huge jumps in vision that was seen in the dexamethasone group. It required less number of injection and less follow-ups. So definitely there is evidence to show that dexamethasone has been a better switch. So finally, in conclusion, the concept of one size fits all may not work. Every diabetic is different. Every anti-VEGF works differently. Every eye is different. In my clinical practice, I start off with ranibizumab or aflibercept initially for 3 or 4 months continuously, and then if it doesn't respond or if there is no response that is adequately seen, I switch to either dexamethasone implant or brolizumab, and then continue with the treatment. So switching at the right time, not early, not late, is very important. So not just check visual acuity, OCT, and inject, but also see visual acuity, OCT, and CME trends over the last 3 months, and then only inject, thus preventing conversion to a chronic diabetic macular edema. Thank you very much.
Thank you, Nameeth.
Thanks.
You do a visual acuity assessment and a scan like every month, or you do it after 2 months or 3 months after the anti-VEGF injections?
After anti-VEGF, at least 1 month I wait for the response.
So
and then I check. Yeah.
What will you answer to the patient if the patient is not improving? Like, do you see that we will see one more drug response? It is very tough.
At least we have to wait for it. See, DME is a chronic disease. We can't promise him instant gratification. It's not possible. We have to wait for at least 4 to 6 months minimum to see any response of any drug. So patience is the key, and this is a long-term treatment. I always advise them it is a long-term treatment. There is no shortcuts to this. Switch is definitely later on, when these things don't work, the normal drugs don't work, definitely we have to switch. But at least trying for 4 or 5 months.
Especially with ranibizumab, I see that if it is not working at 1 month or 2 months, it's not going to work. So I tend to switch even after there is absolutely no response on injection 1, or I also encounter that in few cases there is increase in edema, even after the first injection in some cases. So I see that I tend to change
Yeah, definitely.
like after one. So
Definitely. Another thing which I had mentioned in this talk is that of the late responders. So we can miss those late responders if we switch too early.
Yeah, too early.
That
That's
also is
the
a
point which
problem.
you need to understand. So, most of them they say is, you as per the literature, though you need to wait for 6 months. So the many of them now what they're saying is, even after the 6 months you need to continue them. So we really don't know whether they are not. See, most of the time we call them after a month. Whether there is a delayed response or whether the late response is something which we are missing. So 2 months is too early to switch.
Problem is that we treat this as an ARMD. We think that it is age-related macular degeneration. The three dose
Absolutely,
and
I
then
agree.
PRN
but
is what.
sometimes even before the patient, I think we get apprehensive.
That's
The sir want to.
Yeah.
Yes.
How
yeah.
do we define acute and chronic diabetic macular edema, and how do we know if the patient comes to us at the first consultation in a state of chronic diabetic macular edema?
No, that's what, sir. There's one is the, as Saurabh mentioned, one is the visual acuity
Yeah.
and the duration.
Okay.
And based on these investigations, you can definitely make out with the pattern of edema.
Okay.
Based on that, you can make out whether the disease is very chronic or not.
Okay.
So, based on these things, you can decide what is your treatment modalities, whether the patient is presenting in acute phase or a chronic phase.
Okay.
Okay. Thank you, Nameeth.